Okay, so I'm going to give you guys a little case study review for modules 3 and 4. We're going to go over perfusion and mobility. Okay, so most of these are a lot of the case studies that we talked about. I expanded them a little bit more just so we can discuss them. Okay, so we are back to Mary. So Mary is 68 years old. She presented to the ER with left wrist pain and displacement following an outstretched hand on the stairs at home. She has a history of asthma. She's been treated with corticosteroids. So corticosteroids, loop diuretics, and barbiturates are all three well-known medications that can increase your risk for osteoporosis. Obviously already increased your risk. And then she also had a gastric ulcer. We know some of those medications can increase it too. And she's had a fracture before. Her sister had a stroke, her mom had a hip fracture, and her mom was diagnosed with osteoporosis. So she has a family history of osteoporosis. Not good, not good, not good. Okay, she smokes 5 cigarettes. That can increase your risk. She has occasional alcohol. That can increase your risk. It inhibits absorption. She doesn't do any exercise. She is fully mobile. Cool. So what does it show? It shows something called a Colles fracture. So Colles fracture is what you do whenever you have an outstretched hand, you catch a ball, right? What are the other 3 different types of main fractures you see with somebody with osteoporosis? So a fracture in the spine, compression fracture, fracture in the wrist, Colles fracture, and fractures in the hips as well, right? This is a little bit more about the Colles fracture, same fracture my daughter had. So this is when you catch yourself, or if you're in the middle of doing a back bend and you're 10 years old. Typically, this is a fracture you see with somebody with osteoporosis or an elderly, somebody over the, I shouldn't say elderly, somebody above their 40s and 50s. Postmenopausal woman, you'll typically see this because remember, postmenopause period increases the risk of having osteoporosis, right? When they have that decrease in estrogen, that increases the risk, right? Okay. So there we have our Colles fracture. It was treated. They were able to diagnose her with osteoporosis. They did a DEXA scan. So remember, DEXA scan is what they use to see osteopenia, osteoporosis. If they have osteopenia, it's recommended that they have the DEXA scan every 2 years, all that kind of good stuff, right? So osteopenia, osteoporosis, she gets diagnosed. She's got osteoporosis. We're not surprised. She had 20 million risk factors. So what are we going to do? We're going to teach her safety at home. We're going to teach her about, like, removing rugs, lighted hallways, that kind of thing. Maybe we're going to do some biphosphonates for her because that can definitely help with osteoporosis. So one of the things that biphosphonates is that you want to teach them to take it 30 minutes before they eat at all to increase absorption, and then sit upright for 30 minutes afterwards because of that, reduce the risk of esophagitis, okay? And then our nursing implications. So we'll teach her about any medications that she's going to be on. Of course, if she takes calcium supplements, she wants to make sure she's taking it with 6 to 8 ounces of water because it increases your risk for urinary stones. And then if we're doing any of the other medications, remember those have a little bit higher risk factors. So we're probably going to go with the lower risks before we go to the higher risk factors. So like our estrogen replacement or estrogen therapy can increase the risk for cancer, blood clots, that kind of stuff. So we don't typically want to go to those. And then they also have testosterone, but it's more studied in men and less in women. So we will definitely educate her, and then we're about to review just kind of the things that we keep in mind with fractures in general. So this, we went through Mary's case a little bit fast. We didn't really discuss it with fractures, but let's discuss fractures next. So fractures, when we have a fracture, some of the things that can happen with them, acute compartment syndrome, fat fat embolism syndrome are the two that we said to kind of concentrate more on. Acute compartment syndrome, pain is one of the first signs, but you can also have pulselessness, paresthesia, so the tingling feeling. It can be very pale. You can have even some cyanosis. You can have where it's cold to the touch, the poikilothermia. Paralysis, so they're having difficulty, reduced movement in the extremity. So anytime you see those signs, you want to think of them as an emergency. Remember, you can cause cellular death, and Saunders says it's 4 to 6 hours from the time that it's recognized. So cellular death to that extremity, cellular death to that muscle. Bad, 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 right? And then fat embolism syndrome. So remember, this happens more with the long bones, so a fracture of the long bones. So think humerus, femur, those kinds of bones, right? So if you have a fracture in your long bones, you have a risk of basically letting go one of those little yellow fat cells that can, or emboli, that can be released into the bloodstream. And so your signs and symptoms are going to be very similar to a blood clot. But one of the first signs and symptoms is decreased arterial oxygen saturation. Also, you'll see an altered mental status. That can also be one of the first ones. So really, it's the decreased arterial oxygen saturation is causing the altered mental status. And then you start to see things like chest pain, dyspnea, crackles, increased vital signs, so increased heart rate, increased respirations, right? One of the late signs is petechiae, and this is really the only true difference between a venous thromboembolism, or PE, a pulmonary embolism, than the fat embolism syndrome, is that petechiae, and it happens across the chest. Okay. Okay, so multiple sclerosis, so we're going to talk about Mrs. Baumgardner again. So she is a 70-year-old. She has multiple sclerosis for more than 10 years. She lives at home with her husband at 48 years. He's been her primary caretaker. Upon her last visit to the neurologist, she was prescribed this natalizumab. Sorry. So what are some of the questions we want to ask her? Now, I'm sure you guys remember this from class. So flu-like symptoms. Does she have any flu-like symptoms? This is an immunomodulator. It's going to decrease her immune system. So we want to know if she's got any signs and symptoms of an infection. Other things we might think about. We think about like urinary tract infection, like other infections that she could have. But flu-like symptoms is definitely going to cover just general respiratory type infections, anything else that she could be exposed to. And then we're going to also talk to her about neurological symptoms, right? Because remember, this one can cause that encephalopathy, and that the neuroscience can be some of the first signs that you would see. So with our immunomodulators, they definitely have some pretty heavy risk factors. So making sure that she's not having any new neurological symptoms would be important, and that she knows about keeping herself safe from infection would be important. So this talks about it again. It's that progressive multifocal leukoencephalopathy. And when I kind of just think you should think of it as encephalopathy. It's just one, it's easier to say for me. But two, it will kind of help you remember the neurological symptoms. Okay. And so what else about her? So Mrs. Baumgardner originally had relapsing remitting. So that's where they have a relapse, they get better. They have a relapse, they get better. They have a relapse, they get better. She's been on immunosuppressants for a while. When she gets when she has exacerbations, though, she goes on corticosteroids. What else does that put her at risk for? So we also know that she would be at risk for osteoporosis when she's on corticosteroids, right? And then what about the signs and symptoms of multiple sclerosis? How do you differentiate this from Parkinson's disease? Because we talked about Parkinson's disease as well. So with multiple sclerosis, you want to remember that you have the intention tremors. So you have tremors when they're doing an activity. They don't have resting tremors. So they can rest their hand, but they have intention tremors when they're trying to do that activity. they can have that vision changes. So technically, you're going to see vision changes, you can see motor changes, sensory changes first. Nystagmus is one of the ones that we talked about. You can have like the double vision first as well. Vision changes, your textbook actually lists all three of those, the vision, motor, and sensation. But honestly, if you were to look up like first signs of multiple sclerosis, you're going to see vision almost always mentioned. And so that can sometimes be the very, very first sign for multiple sclerosis. But they have multiple different issues like dysarthria, dysmetria, the hypoalgesia that we talked about less. They can feel pain less. And so if you think about anything that can really be caused by the breakup of the myelin sheath, that's what you see with multiple sclerosis. So Parkinson's disease. Okay, so we're going to talk about Mr. Connolly again. So here is signed to care for Mr. Connolly. He was admitted to your post-op unit. His vital signs are stable. His vital signs have returned. He's on D5 half normal saline. Surgical site's clean, dry, and intact. He's ordered oxycodone for his pain. He has mild hypertension, benign prostatic hypertrophy, degenerative joint disease, and Parkinson's disease. During team huddle, the surgeon and the medical resident, you report concerns with Mr. Connolly that his speech is slurred, soft, and slow, and his face is expressionless with some drooling. He has a noticeable resting tremor of the right hand. So we know that these are some signs of Parkinson's disease, right? So we see the soft, slurred, soft speech, expressionless, and drooling, right? Resting tremor. He's got the pill rolling, so his hand is kind of just continuously tremor. It has the tremor, continuous movement of his hands. It can be often the first sign for Parkinson's disease. Arms swinging with rockings, excessive salivation, blinking, blank facial expressions, stoop posture, the cogwheel rigidity. So when they are not able to do smooth movements, okay? Why? Because you have no dope in the park. So you have a decrease in their dopamine production because their area of their brain that produces their dopamine has been dying, right? That substantia nigra part of the brain, the basal ganglia part of the brain has died, so it's not producing that dopamine, which helps balance your acetylcholine out, right? The acetylcholine causes that increased muscular rigidity, which is where you see that cogwheel-like movements. So going back to our medication, so he's got home medications of carbidopa, levodopa, 3 times a day, the terazosin, which is for that BPH and antihypertensive as well, the Celebrex, which is for his joint disease that he has, and then the SSRI because Parkinson's disease can cause depression. He really needs that swallow consult because if we know that his speech is soft and slurred, we are also concerned about his ability to swallow as well. Okay. So our immediate safety concerns is the swallow and also falls, right? Those 2 things are important. And then medication reconciliation. We really need to make sure that he's getting his meds because that's going to decrease his risks. So looking at our priorities, we already just talked about this, the aspiration risk, that swallow study is really, really, really important for him. And then a falls risk, and knowing, with Parkinson's disease, having that sticky feet. So making sure that they know to take big, gigantic steps to try to speak louder, we'll talk about that later, is important. And then medication reconciliation, making sure he's getting his meds. We're going to talk about that in a second. I'm not going to jump ahead, but we're going to talk about that in a second. So how are we going to address these concerns? We should be calling your provider. We should be talking to the pharmacist. We should be making sure he's getting his medications. We should be getting that swallow study done. We should be having him on aspiration protocol, fall risk protocol, all the things. So we're going to assess his gag reflex to reduce his risk of aspiration out of the bed for chair for meals, full Fowler position when possible, speech swallowing consult, super important, and then he needs his medications on time to improve his muscle control, right? That levodopa needs to be basically replacing the dopamine that was in his brain. That's going to decrease the rigidity of his muscles. Very important. So to reduce his risk of falls, this stuff I know you guys know pretty well, but making sure his call bell is within reach. He's changing his position slowly because carbidopa, levodopa, and terazosin both cause orthostatic hypotension, right? Administering his medications on time, super important. So we know that carbidopa, levodopa needs to be on time. Patients experience on and off effects with their medications. When we have it where it's off before their medication, they're going to have increased symptoms. So making sure they're on time is really, really, really important. Medications can cause that tardive dyskinesia, the uncontrolled movements of the face, eyelids, mouth, tongue, arms, hands, legs, squirmy movements. So being able to monitor for that is important as well. So what concerns do we have for his medications? Well, we want to make sure that there's no interactions. Doing that medication reconciliation is important, making sure he's getting his medications. So we give it before meals. It's going to increase his absorption. We want to monitor for long-term use because that can cause that dyskinesia. Bodily fluids may be darker, so educating them about that. Protein and B6 can interact with the medication. So I did find in Saunders they talked about the B6, just to kind of reiterate that. So encourage our protein meals more at the end of the day is important. Terazosa and carbidopa, levodopa both cause orthostatic hypotension. And then our Celebrex can sometimes decrease the effect of our terazosins. That's good to know. Parkinson's disease they can experience depression, so that's why he's getting that SSRI. Another SSRI that they might use, MAOIs or MAOBs they might use. So MAOBs can increase the dopamine, which is great, and affect their depression. But remember, MAOIs, MAOBs, always educate to avoid tyramine, right? I know you guys know that. I know you do. But that's always an important piece with that. And then some of the other medications, anticholinergics, also can improve the symptoms of Parkinson's disease. But we're going to be really cautious about using it. We're probably not going to use it in our elderly patients because that's one of those Beers List medications that we learned 2 weeks ago. Okay, so carbidopa, levodopa, our levodopa works with our carbidopa. Our carbidopa decreases our body's ability to just get rid of that, metabolize that levodopa, and then the levodopa is able to act as our dopamine replacement. And then we also have MAOBs. Remember, avoid tyramine. Inhibits the breakdown of dopamine, are COMT inhibitors, so they slow down the breakdown of the levodopa. This can help if you're having off times before the medication is due. And then our amantadine is an antidyskinetic. It helps promote the effects of dopamine. So Mrs. Connolly arrives. She says he hasn't gotten his pills yet. I know you guys heard this story, so I'm sorry for going fast. So what do? We need to apologize. We need to acknowledge concerns, make sure that our provider and our pharmacist are aware of this and that we get that medication now. We need to make sure he's safe to eat because that can definitely affect his aspiration, risk for aspiration. So very, very important. So we're going to observe for a therapeutic effect. We know the on and off phenomenon. We already talked about a lot of this. And then orthostatic hypotension, very important. We want to make sure that he is not at risk for aspiration. And some things to work with him on speaking louder, making sure that he has an intentional effort to speak loud. Don't finish his sentences, so that's always important as well. And then working with the physical therapist to start some exercises. Exercises are definitely a neuromuscular protective factor. So doing that and then working with Mrs. Connolly to understand why we're doing it is important. And then doing exercises that are going to help, and providing pictures and explanations of what they can do at home to help is good too. Regular diet is delivered from Mr. Connolly. He attempts to eat, but complains that is too much work and he's not hungry. And so what are some things that we could do for Mr. So what are some things that we could do for Mr. Connolly? Let's go back and kind of think about this. So remember, the best diet is going to be a high protein, higher caloric diet, but we don't want the protein at the beginning of the day. We want it at the end of the day, right? So yeah, so our high protein, but more at the end of the day, preventing constipation with high fiber and good hydration is really important. Concerns with caffeine is always an issue. So, monitoring that, it might improve their drowsiness, but it could aggravate their symptoms as well. And then they're always at the risk for aspiration, so working with what food is best for them, what they'll actually eat, but also smaller bites so they have less risk of aspirating. After a few days, he's ready to go home, so we are going to talk to her about everything that we just discovered with this, right? So making sure she knows like exercise is neuroprotective, encourage loud speaking, encourage big steps, promoting independence, promoting his ability to like talk and communicate for himself is important as well. Evaluating the effects of the medications is going to be important. Making sure he gets discharged with the right medications, a good list, a good solid education for her on the list is important as well. And we might want to start an aspiration protocol and a ball risk protocol for him for all patients with Parkinson's disease after our experience with taking care of him. Okay, so Cassie is a 24-month-old. She's been diagnosed with cerebral palsy, spastic depletion. I can't say it. So that's that hypertonicity, right? They adopted her at 4 months old. They had no prior knowledge about what other issues she had. So remember, your preterm birth is definitely a risk factor. Your perinatal and neonatal infections are definitely a risk factor. Your stroke are definitely a risk factor. Any hypoxia during pregnancy, intrauterine period, or afterwards is definitely a risk factor. Anything that's decreasing the perfusion to the baby's brain, preterm birth, extremely low weight birth, very low weight birth are definitely risk factors. Okay. So with this little one, we have and hemorrhage as well. Like I said, anything that's perfusion. For this little one, she's not meeting her milestones, so they noticed that her legs also appeared stiffer because remember she's got that hypertonicity. Eyes did not appear to work together. She couldn't focus with one eye at one time. They were concerned about cerebral palsy. And remember, one of the things that you see with cerebral palsy as well is you see that seizure activity too. So they're working with their pediatric ophthalmologist to address the concerns about the strabismus. That's where the eyes are not working together. And they're doing the Botox injections. Remember we talked about that for kind of decreasing that spasticity or the rigidity, really, the rigidity of the muscles. There's actually very poor medications for spasticity. So what was that one thing that we talked about that was really that was better and it was more recent was the baclofen. So baclofen has been effective for spasticity, and it's intrathecal, right? You guys remember that? And so she's doing physical therapy to control it, and the Botox treatments are definitely helping. She's able to crawl around the house using primarily her arms. She sits independently, but sits most often with her legs in a W position. That actually can be a sign that you have a child that's having gross motor issues, because maybe not good core strength. It also can really, really be bad on their knees and their ankles. It's not a position that physical therapists like to see. It's not a position that pediatricians like to see. It can tell us, one, that they might not have quite the core strength that they need, and two, it can tell us that they might have issues walking and moving and everything, and it can just wear down your knees and your ankles for future. So she uses a small walker with adult assistance. They've been working on her mobility skills and working on, she lacks smooth control of her arms and her hands, because remember that hypotonicity. So her movements are not very precise. So remember, with CP, it's really a mobility issue that has been caused, and it can also have cognitive impairment, but may not. It can be caused by that brain damage from the lack of perfusion to the brain. So kind of knowing like the cause of it, and then being able to work with them within their abilities and trying to maximize their abilities to adapt and overcome, because the brain is amazing and it can really overcome a lot of that, is important. But knowing that they do have this mobility issue is not progressive. What you see is kind of what you get, in that what they first are able to do, we are going to continue to try to get better at. That's what it means. It means it's not progressive like Parkinson's disease, where it's going to get worse and worse. So, we talked about like the developmental issues. So she should be, I think she was 3. She should be able to walk. She's still struggling some with words. So her peers are able to, she can name some of the pictures like her peers, but she can't accurately point to a picture like her playmates. So she might have a little bit of a cognitive delay. But it does sound like she's doing pretty good when it comes to that. So she's keeping up. She might be a little bit delayed, but it does sound like they're working with her really well. Her language skills appear to be developing well. She enjoys talking using 2 to 4 words and sentences, and that's all really good. She labels objects, requests toys that she cannot reach, and likes to tease. So overall, her cognitive abilities seem to be close. Maybe a little bit delayed, but overall doing pretty well. So it sounds like it's more gross motor. And then concerns with her, with the hypertonicity. Is epilepsy also a possibility with her? So safety with mobility is big. And then, working with her for physical therapy to see if she can improve, because oftentimes they can get better with that walker and be able to move better. So working with her within that would be important. And so, and then if she's got that increased spasticity, being able to do maybe the intrathecal medications might be good. There are other medications like the baclofen, dantrolene, and I think it was diazepam, if I remember correctly, that they talked about with spasticity. They're not as effective. I'm just going to say that they're not as effective. The intrathecal sounds like it's one of the more effective, but it's definitely hard to manage. And then the anticonvulsants are only for seizure activity and not for the increased spasticity. So that is all I've got for you. I know CP is a really quick one, but that's all I got for you. I hope this helped. I hope this definitely helped wrap it all up for you guys. Please feel free to email me if you have any other questions. And if it helps, I can always just start the discussion board too. So if you guys would like that, just let me know. Okay? Thank you.
Okay, so what we're going to try is just adding in these development slides. You guys will have to tell me how well you feel this helps you prepare and review. I, for the sake of time, decided to use the ADHD case study that we used before, and I'll kind of talk and add a little bit more through it as we go. So, of course, we have that 8-year-old female client. She presents to child psychiatry clinic with her family member. Child was referred by the family health care provider who is concerned about her behavior at home and in school. The nurse checks the child's vitals, height and weight, vital signs, heart rates, 121, which we know according to our US book is just a little bit elevated, but really is not necessarily an abnormal variation. Respirations are 24. Blood pressure is 100 over 70. Oxygen saturation is 98%. Temperature is 98.6. Height is 50 inches. Weight is 50 pounds. Initial history is conducted. The aunt described the child as very energetic. She's carrying and likes caring for her family's cats at home. She loves watching motor and cycling sports and playing board games. The child has been living with her aunt, her father's sister, since 1 year after a child divorced 3 years ago. Both work and live overseas, and the child, my dog is trying to join this video, and the child's been living with her aunt, her father's sister. Oh yeah, sorry. The aunt reported that her child's mother had no pregnancy, birth problems. Child has completed her immunization shots and is not taking any meds. They visited and observed the child at home on the following day. She has a lot of energy at home, can't sit still, eats only small portions of food. Her 2 cousins describe her as the center of attention. She's stubborn, spoiled, always gets in fights with them. She has sleep difficulties, a disorganized room, and cluttered notebooks and school bags. Child avoids homework, resists bedtime, hardly wakes in the morning, is slow with routines, and takes a bath for only 2 minutes. They visit the child at the school and meet with the child and meet with the teacher. The child's been seen as having challenges with educational materials and task completion. The teacher describes the child as impulsive and has social difficulties. The teacher reported that the child would have a friend, and then suddenly they were not friends anymore. In addition, the child was observed to lack self-control, was messy, it was primarily non-performing in academics. So remember, you want to see it in 2 different settings, 2 separate settings. The child returned to with her aunt on the 5th day. Healthcare provider conducted a semi-structured questionnaire, and the Wechsler's intelligence scale for children was used to obtain the level of intelligence. Child and adolescent symptoms inventory 5 is used. And remember, they're going to be using that DSM-5 to really be able to diagnose this, and this is going to be through interview structure. Interviews that are done outside of the setting and inside the home as well. To be able to diagnose it. The medication that they're going to be choosing, what 2 medication orders. So methylphenidate is the medication that they're going to use. It is started with a low dose and then moved up, specifically targeting the symptoms. So we're trying to manage the symptoms while also decreasing the adverse side effects of it. So some of the contraindications for methylphenidate, don't remember. Contraindications like heart disease, coronary artery disease, hypertension, glaucoma, that kind of thing are things that we would consider big time contraindications for methylphenidate. And then going into the side effects, you can kind of expect some of the similar side effects to what is the contraindications, right? So contraindication for hypertension, we know that methylphenidate probably speeds up, it's a stimulant, so it can cause hypertension. So there's side effects that we're concerned about and side effects we're not as concerned about. The side effects we're not as concerned about, you might have headaches, you might have some insomnia within reason, some diarrhea within reason, some nausea, vomiting within reason. But when it gets to that point where it's starting to affect your heart, that is concerning. So when we start to see things like palpitations, that's my child. Nope. When we start to see things like palpitations, when we start to see things like hypertension, that is when we really know that it's too much. They should not be on this medication, right? So we either need to lower the dose depending on what it is, or take them off it, switch them to another medication. No, Amelia. Nope. Okay. And remember that really, really life-threatening side effect is the hepatotoxicity, where you see this blood dyscrasias, meaning things like bleeding with your gums when you're brushing your teeth and you're using floss, bleeding like petechiae, purpura, that kind of scary, horrible things that you see when you have hepatotoxicity. those would be the life-threatening ones. So I don't really have awesome case studies to talk about autism spectrum disorder. Well, I do and I don't. If you go to the link that's in the below part of the slides, you will see there are multiple case studies in the sensory processing Middletown autism. They're really, really, really interesting. But I think what's hard to use one of them is that there's such a wide range of what you see with autism. So it's hard for me to just pick one case study that's going to be like the ultimate case study for you guys to review it. So instead of doing that, I just kind of figured I'd hit on some of the developmental review points. So things like, developmental issues. Developmental issues, like we start looking at what kind of developmental issue it is when a kid doesn't meet their milestones, right? So when things happen like, okay, well, you're not sitting up and not even close to it, and it's over 6 months. You don't have head control, and it's at 4 months. There are certain things where you just start to watch them closer. Now, sometimes it can trigger where they're now being followed by a developmental piece. Sometimes it just triggers, okay, well, we're going to monitor it and we'll see where they are in 2 months. It's okay for kids to meet it within reason. Like you want to say almost 2 months before, and sometimes even kids meet it 2 months or 2 months after, and sometimes even kids meet it like 2 months before. That can be within normal, but we watch that. So when you're talking about autism, remember you're really starting to think about how they are with that socialization. Your 4-month-old baby should be able to kind of interact and smile a little bit, right? Your 9-month-old should be able to say, they're typically saying mom and dad, but at the very least they're making some good babbling noises, right? And then by the time that they hit that 2-year stage, of course, that's when we're really expecting to see like those 2-word sentences. Okay, that's kind of a big marker for people, for kids, because they can be a very wide range and not necessarily be on the scope, not a kid that we're considering on the spectrum. So, going back to the developmental milestones, primitive reflexes that are normal in a neonate. Remember the Mara reflex, tonic neck reflex, and the Babinski reflex are all 3 really normal in a neonate. When you see them afterwards, that's when it gets concerning. Tonic reflex doesn't have quite as clear of a definition, like it goes away at this point when I looked in your book. But definitely the Mara reflex, they talk about how it should go right around, well, they kind of also are not very clear, but it's about 3 to 4 months. The Babinski reflex is about a year. And so when you start to see these reflexes and it's still going on, that should ping for us that's abnormal. We know that Babinski is not normal, right? So when we see that, it says something is going on with the neurodevelopmental issue with this child. When you think about growth and development, you always want to remember that independence is one of the very first goals, one of the main goals with growth and development. So we really think about survival, and so self-feeding, like bing bing, that's an absolute first goal. So things like if I'm working with an autism spectrum disorder child, things like when he's able to finally feed himself, use a fork, that kind of stuff, that is like a boom, big time good, right? So the 3 developmental issues, you have cerebral palsy. That one's the one that's the first to show. It's your non-progressive disorder. It might be something that we're going to suspect if you have a preterm baby that's not meeting their milestones when they're expected to. Then autism spectrum disorder, we might see it as close to around 2 to 3. So you have this sensory, communication, socialization, behavior sometimes. So again, it's a wide spectrum. And I'd say that we are definitely 1,000 times better at understanding it and diagnosing it than we were even when I was a kid. But I still think there's a lot we don't know. ADHD, it is typically seen more around, like we start actually talking about diagnosis around 7. And again, there's different textbooks have different definitions about that. Some textbooks have said that they don't even diagnose it until 7. I actually know that they're doing a lot of research to see just how early it could be possibly present. And some textbooks talk about how, oh, it goes away as teenagers. Well, we all know that that is not true. In fact, if you look at a lot of the people that are on stimulants for ADHD, you'll find that there's a larger adult population that are on it now, and I think that's because we're normalizing it finally. So the interventions with kids are always going to be directed to the developmental stage, and that'll just bring me to the next slide. So we're going to end with just a quick case study. This is from a whole entire other case study, but it's a nice way to talk about, how we target where their developmental stage is. So the healthcare provider determines this kid had a viral fever with dehydration. The nurse checks the provider's prescription and confirms the treatment orders with another nurse. The parents are concerned about the child's treatment and ask the nurse how to administer the medication to their child. The nurse provides the parents with a teaching session. Which teaching would the nurse provide for the parents for the child discharged? 1. Provide a short and simple explanation to your child before giving the med. 2. Give the medicine to your child and allow them to instill the syrup directly into their mouth. 3. Remember to reduce your child's stress and any pain associated with drug administration. 4. You will need another person to support your child's arms and knees while administering the medication. 5. You may need to give chlorpheniramine malate to your child when they have a runny nose, watery eyes, or mild cough. 6. You should learn the drug absorption, distribution, metabolism, and excretion to fully appreciate the treatment. No, that's true for you, nursing students, but not true for parents. 7. Use an oral syringe when administering the acetaminophen syrup to your child if they won't take it by a spoon. 1, 3, and 7 are your answers. So just remember, when you're studying it, the differences with kids and with our elderly, we know that it has decreased absorption. We know that we have decreased metabolism. We have a huge concern for toxicity. And that is all I got. Thank you.